Hi, my name is Christopher Voscopoulos of Medical Specialist Associates, and thanks for watching this topic on best practices in the treatment of COVID-19.
Medical Specialists Associates, making medical education more accessible.
Hi, my name is Christopher Voscopoulos of Medical Specialist Associates, and in this talk we present best practices in COVID-19. This is our current treatment approach to COVID-19, and the date is October 12th, 2020. Now that's important because, as we know, things are rapidly changing in terms of treatment of COVID. So please keep this particular date in mind, as just a few weeks or months can go by to where things could really change in the treatment of COVID. But for now, this is how we're currently managing our COVID-19 patients. First, a little bit about COVID, just to make sure that we're on the same page. So it is an RNA-enveloped coronavirus, and we currently believe that it possibly spread from bats or pangolins to humans, but at the current moment, its primary spread appears to be person to person, and that takes place through respiratory droplets. Hence, that's why most countries are wearing masks at the current time to reduce the number of droplets that are aerosolized. So how exactly does the virus get into our bodies? Well, we come into contact with these aerosolized droplets, and they come into the lungs. And within the lungs, viral S spike parts of the RNA virus bind to our ACE2 receptors on type 2 pneumocytes. And that's how the virus actually gets into the body. Now, other spreads could possibly be relevant here, but we're unclear at this time. So what are some of the epidemiological measures that we should know about? Well, one is the attack rate, which is about 30 to 40%. Now, the attack rate is a biostatistical measure of the frequency of morbidity or speed of infection in an at-risk population. Now, here, the case fatality rate, I'm going to briefly glance over. And the reason why I'm glancing over it is because now that we're having so many new treatments come out, we're starting to see this number downtrend. And at the current moment, it's hard to know exactly what this number is, again, because now we have things like steroids and Remdenzavir, et cetera. So the incubation period is about 4 to 14 days, and it's up to about 15 days. And there appears to be a particular number that we see in ICU patients, and that's somewhere between 8 and 10 days to where a patient decompensates. It's not uncommon to have a patient admitted to the floor, say be at day 3, 4, 5, or 6, and then they continue to progressively decline. And then around day 8, 9, or 10, they require intubation. And this is what we've been experiencing. Viral shedding. Now, this number could be a bit deceiving. Median days is about 20 and max is up to 37. However, what's not expressed in this particular number is whether or not the virus is live. We think that once you go past approximately 14 days or so, that if you are shedding virus from the time that you are symptomatic, 14 days after, that the virus is likely inactive and people aren't able to catch the new infection from viral particles that you might release. Now, perhaps a number that's not given enough attention is what's called the excess death rate. So what exactly is this? Well, let's say if you are a 90-year-old gentleman with multiple comorbidities, and just as fate would have it, you were going to pass away in the year 2020 anyway. However, unfortunately, you contracted COVID, and COVID brought about your demise. Well, in terms of excess death rate, we would not count that as a death towards COVID because you were going to pass away anyway within the year. So as we get close to the end of 2020, it'll be interesting to see what this excess death rate is so we can really see the full impact of what COVID-19 has had on countries. So what is our current worldwide strategy for containment? Well, this virus is amazingly infective, and as such, we really don't think that it's possible to totally contain it. And because of that, what we've concentrated our efforts on is to slow the spread. So what this shows right here is without any protective measures, say no face mask, no social distancing, what would happen is you'd have this huge spike in cases, and you can go above what the healthcare system capacity can handle. And then this becomes truly unfortunate, because then there could be multiple patients that we could possibly save, but we simply aren't able to. We only have so many ECMO circuits, only so many ventilators, and we've just gone above that number, and we have to begin to triage. So our primary focus really has been, with the protective measures, is to keep this curve below what our capacity, so that if you did contract COVID and you did require hospitalization, that us in the medical community could provide the best possible care to you without having to triage or ration healthcare resources. So what about diagnosis and presentation? Well, about 65 to 80% have a cough. About 45% upon initial presentation to you might be febrile. However, up to 85% of people will be febrile at some time during their illness. 20 to 40% present with dyspnea. 15% with other respiratory type of infectious symptoms. Now, this is interesting. Up to 50% of patients can have GI symptoms. And what we've seen in some patients, especially at the beginning of COVID when this was less known, was that some individuals presented with some GI complaints and they were admitted to the floor for a possible workup of acute cholecystitis or maybe appendicitis or other GI enteritis symptoms. And they ended up testing positive for COVID. So this is something to keep in mind. And up to 80% of people will have loss of smell. And when you have loss of smell, you also have decreased or loss of taste as well. So on the laboratory side, this is very interesting. The first one here, a leukopenia, lymphopenia, you will see decreased lymphocyte absolute count. And in this day and age, when you see that, you really start thinking of COVID irrespective of what maybe a COVID antigen test might say, positive or negative. In addition to this, the common things that I'll focus on here is that you will see a elevated D dimer, and you will see an increased CRP as well. If you do have the ability to test for interleukin-6, this can be helpful. Sometimes early in the course of illness, the interleukin-6 might not be elevated yet. And this is because in the early part of the illness, you see more of the effects of the virus. But as people survive longer and time goes on, then you see more of the effects of the immune system kicking in. So you might need to repeat an interleukin-6 later on. And if it's just a viral illness, of course, you'll see a negative procalcitonin. So this is important to keep in mind because our antigen tests are not 100%. And so if you see someone come in, say, with a lymphopenia, a profound lymphopenia, an elevated D dimer, and say an increased CRP with a negative procalcitonin, most of us at this point in time would consider that patient positive for COVID and would likely begin treatment for COVID and repeat antigen testing. That's important to keep in mind. So what does this look like on imaging? Well, the chest X-ray shows hazy bilateral peripheral opacities. And with CT scanning, we could see maybe one of three patterns. We can see our typical ground glass opacities, which here we see out in the periphery. We can see what's called a crazy paving pattern. And this is the same ground glass pattern that we saw in the prior image to my left. However, you also will see here this superimposed inter and intralobular septal thickening. And then, of course, you could also see a consolidation pattern. So here's a consolidated lesion with air bronchograms as well. So this is one symptom maybe that has not been given more attention, and that is oral lesions. And the reason why we highlight this is at the current time, most of us are trying not to intubate these patients and allowing permissive hypoxia, which is something that I'll talk about later in the presentation. However, high flow nasal cannula tends to be better humidified, but BiPAP we can maybe struggle with. And if individuals have oral lesions with excessive or prolonged use of BiPAP, you could get irritation of the oral mucosa all the way down to the vocal cords. And we have seen during the time of intubation that people had literally ulcerations throughout their entire oral cavity down to the vocal cords. And it was very thick and difficult to rub off because it was so dry. and this made intubation very difficult. And unfortunately, this could be missed because having oral examinations on a daily basis is not easy. It's not easy because these patients are BiPAP dependent. And if you take the BiPAP off, they desaturate immediately. And then there's also the risk of exposure when you take off the BiPAP and the patient is breathing out into the air. That being said, we are taking greater care these days to do at least daily oral examinations with individuals wearing a PAPR. So what about some precautions? Here I'm going to just briefly go over this here. This talk is really more about treatments. And if a patient presents and has no respiratory distress requiring treatment, we're telling that individual to go home in the quarantine for 14 days. And the reason why that is because we want them to become either virus negative at the end of the 14 days or have inactive virus to where they can't transmit it to other people. And down here, the only thing maybe that I'll really concentrate on is the use of N95 mask or PAPRs during aerosolizing procedures, such as intubation or bronchoscopy. Otherwise, it appears that just wearing a regular face mask is acceptable, again, outside of those aerosolizing procedure. And the one point that I do just want to emphasize again in terms of individual safety is that maybe if you are checking the mouth on a daily basis, based on my prior slide, is to make sure that you are wearing an N95 mask or PAPR for protection. And again, that is important because you don't want to be alarmed during intubation that you didn't realize that a patient had ulcerations all the way down to their vocal cords and had a very difficult intubation. That's not the time to find that out. So what about some of the treatments that we're using? And so I'll try to go over the ones here that are in the yellow, and I'll just briefly just mention maybe vitamin C and flow-land nitric oxide here. Vitamin C, there has been some information about vitamin C having beneficial effects, maybe with via some of its antioxidant properties, maybe in helping to strengthen the endothelial lining. Which we'll talk about a little more with COVID maybe being a little more of a vasculitis as we think of right now. However, most of the research has been done with IV formulations of vitamin C, and that's currently not available in the US. And it's highly unlikely that we're able to get to the doses with the oral form due to its limited bioavailability and some of the GI side effects you get with some of the higher dosages. Flow-land and nitric oxide can both help with some VQ matching. There has been some information that perhaps maybe nitric oxide can also be beneficial in addition to helping out VQ matching, that it might also be lethal to the virus as well. So before I talk about some of the treatments, though, I wanted to talk about something that's maybe a little more hopeful. And that is that this information was presented at the last European Society of Critical Care Medicine Society meeting. A presentation there talked about how lung function improves at 12 weeks in COVID in some of these long haulers. Now, this is important because there's great concern of what's going to happen to some of these ICU patients that we're taking care of, and they've been on mechanical ventilation for so long, and they finally come off. Will they have lifelong pulmonary problems, etc.? And this was very hopeful that this came out, that around the 12-week mark, people are showing substantial, if not full recovery of pulmonary function at that time. So this is very hopeful and something for us to keep in mind when we're really in the midst of treating patients in the ICU and they're at their sickest. So before I talk about some of the treatments, again, I want to underscore our current understanding of COVID. So COVID is a very interesting disease that's affecting the brain with stroke, the kidney with kidney failures, the lung with respiratory insufficiency, the hematologic system with thrombosis. And what's one thing that could put all these things together? And that is a vascular insult, a vasculitis type of injury. And that could help put all of these different body systems together that are being infected. So it's more than just the lungs. And again, we're starting to look at the endothelium more closely in this particular entity. So, I mean, you have to start this particular treatment section off with dexamethasone. So many thanks to the British for studying dexamethasone, an extremely affordable treatment, and in which they showed that the use of 6 milligrams daily for 10 days in individuals that were symptomatic that required oxygen, they had a decreased progression to intubation, and they had decreased mortality. But what about us in the ICU? What if we had a particular patient that goes beyond the 10-day course and they're requiring prolonged ICU care? Well, in them, we treat till the time that they are discharged home. So it's 10 days, unless if the patient is not better. If they require continued hospitalization, we continue with treatment. So why do we think that these steroids are beneficial? Well, this is interesting. This particular paper here talked about the differences in the immune response compared to the pediatric and the adult population. And what we find is that in children, interleukin 17 and interferon gamma were elevated. And this appeared to be beneficial in the elevated in the pediatric population, and this appeared to be beneficial and allowed them to handle the virus more. But in adults, tumor necrosis factor alpha and interleukin 6 were more elevated, and those seem to have had more detrimental effects. What appears to be happening in some of our adult patients, and especially those with comorbidities, is they're having such a robust response to the virus, and they're producing so much tumor necrosis alpha and interleukin 6 that it's really the immune response that is driving the deleterious effects that we see in these patients. Now, when we come back to our 6 milligrams of dexamethasone, now that's not the highest dose in the world, and there are many conditions that we treat much higher dosages of steroids with. So perhaps here the focus is not obliterating the immune response. The focus is more maybe in bringing back into alignment the immune response, tampering down that robust response, having less interleukin 6 being secreted, but still allowing some of the beneficial cytokines to be produced so you can have a healthier adaptive immune response. And later we'll see of more treatment therapies that maybe target decreasing the levels of interleukin 6. So what about Remdenzavir? Well, this treatment is now widely available, and what do we know about its effects? Well, it tends to decrease the length of illness by about 4 days, but an important thing to note here is that for our current information that we have on the particular research, that it has no apparent effect on mortality. So perhaps what we have to do is treat many more patients and have a higher N number, and maybe we'll see a very high number needed to treat number to reduce mortality. So it might end up having some benefit, but we don't know as of yet. And of course, we need to remember that we cannot use remdesivir in those individuals with acute kidney injury or chronic kidney disease, or in individuals who are on vasopressors. So what about cholesterol, and what about its effects in helping to minimize the morbidity and mortality of COVID-19? Well, this particular paper was interesting, and this talked about that if you depleted the cell membrane of cholesterol, well, then you reduce the virus's ability to get into cells and to replicate, because the virus needs that cholesterol. So, of course, what drugs do we have that can accomplish this? And those would be our statins. And we are currently seeing use of statins in COVID-19 patients. Now, what we don't know is how low to target cholesterol. Should we maybe use higher dosages of statins and target very low dosages of cholesterol, at least during our active phase of COVID treatment, maybe getting the LDL cholesterols maybe less than 100 or so? This is still being worked out, but it does appear as if statins might play a beneficial role in treatment at this time. So what about vitamin D? Well, this was an interesting paper here, and it talked about how individuals who had low levels of vitamin D had increased risk for COVID-19. And this appears to be because vitamin D is very important to help a healthy immune system, and more particularly a healthy adaptive immune response that we saw with the difference between the pediatric and the adult populations in terms of the differential expression of cytokines. So then the next question really is how much vitamin D to give people and what's normal for vitamin D? Well, over here I show your typical RDA requirements. And here I concentrate on if you had plasma levels, what would be normal plasma level? Well, normal plasma level would be anywhere from 20, I would say more like 30 nanograms per ml up to 50 nanograms per ml. And it's important to keep in mind that you could have toxicity. So above 75 nanograms per ml would be toxic. So if your particular laboratory has the ability to have rapid vitamin D levels, this would be helpful to find out, to see those individuals that might be deficient in vitamin D. And you might be very surprised. A large portion of the US population is deficient in vitamin D. So the current recommendation for the daily allowance is about 600 to 800 international units. But during this time, it does appear to be reasonable to treat with maybe 1,000 to 2,000 international units per day of vitamin D. And to keep in mind that people can overdo it. It's very common for people to think that something's helpful and they just simply take too much of it. So vitamin D toxicity can occur with very large dosages of 5,000 to 10,000. So let's say then you do get a patient and you do have the ability to have plasma levels and you find out that your patient is deficient in vitamin D. At that point in time, it might be reasonable to consider treating with higher dosages of vitamin D, say 10,000 units for a week or so. Here, the point is not to continue with those high levels, but to give high levels upfront to more quickly bring that patient's plasma levels back up to what they should be. Also keeping in mind that during acute illnesses, patients might have decreased bioavailability, et cetera. And so we're not really quite sure how much of the vitamin D that they can absorb to begin with. So what about zinc? This particular article here focused on zinc levels. And again, it appears that zinc isn't important in that adaptive immune response, and low levels of zinc, just like the vitamin D, appear to be deleterious. So a normal range, healthy range for zinc is 70 to 120 micrograms per deciliter. The RDA is currently listed here, 8 milligrams a day for women or 11 milligrams a day for men, higher in pregnant ladies at 11 milligrams per day, and even slightly higher for ladies who are lactating, and that would be 12 milligrams per day. So what are we treating patients with right now in terms of zinc? Well, it'd be helpful if we can get a plasma level. And then we can give higher dosages of zinc, say 20 milligrams per day, or BID appears to be reasonable. Again, giving higher dosages of zinc to more quickly bring up those levels so that it can have the beneficial adaptive immune response quicker, instead of giving maybe RDA levels and just waiting a longer period of time for the zinc to come up to what the normal levels should be. So what about ACE inhibitors and ARB treatment in COVID-19? So here was an interesting paper. And so this meta-analysis, including critical events and mortality data, was on patients prescribed ACE inhibitors or ARBs, and they found evidence of beneficial effects of chronic ACE inhibitor ARB use, especially in the patients that had in the hypertensive cohort with COVID-19. So it appears that since the virus gets into the body via the ACE2 inhibitor, that blocking the ACE receptor might have some beneficial effects. And so perhaps at this particular time, we should encourage patients to continue with their RAS inhibitor pharmacotherapy during the COVID-19 pandemic, and maybe even take it one step further. Say if an individual is is admitted to the hospital, they're new onset hypertension, or they haven't been treated for hypertension before, perhaps maybe we should be considering our ACE inhibitors, ARBs, as our first line antihypertensive treatment modality in the hospital and in the ICU if that individual has COVID-19. So what about convalescent plasma? Well, the Mayo Clinic has done just a fabulous job in coordinating this particular study. And in their early analysis of their current findings, it appears that some of the takeaway points for convalescent plasma that we should keep in mind are that it's likely best if used earliest in the stage of the disease. And so how are we approaching this? What we're doing is that the second patients are presenting to our hospital and admitted to the hospital, we are consenting them for convalescent plasma right there and then and trying to get it on board within 24 hours. It also appears that higher titer plasma appears to be more effective. Now, this is interesting because then this begs the question, perhaps maybe in some of our sicker patients, instead of treating with just 1 or 2 units of convalescent plasma, since again, we don't know what the titer levels are, is it possible maybe to use additional dosages of convalescent plasma? And might that offer benefit because we're giving more higher titers of antibodies? Or do we need to balance risk factors such as it's a blood product, and the more blood products we give, there are risks associated with that. And so there really is a trade-off, and it's an interesting question to at least consider in some of our sicker patients. Now, again, this might change in the future when instead of giving convalescent plasma, we might start giving bioengineered and synthetically derived antibodies. So what about thrombosis and anticoagulation in COVID-19? Well, this is exactly what we're seeing. We're seeing these individuals with multiple microthrombi, which is exactly what we think is going on in their lungs. This appears to be a microembolic disease, as well as maybe some VQ matching difficulties, which we'll talk about later. And so this really begs the question, how do we manage this? So what it appears is that normal prophylactic anticoagulation does not appear to be effective, say with 3 times a day heparin, 5,000 units TID, or with prophylactic dosages of Lovenox. So in order to consider treating patients with treatment doses, maybe perhaps a practice can be here that you can look to see if the D-dimer level is 3 times normal. And if it is 3 times normal, perhaps then it is reasonable to go ahead and treat with treatment dose Lovenox or heparin, because again, people are breaking through with prophylactic dosages. Now, this also begs the question for us to help with our ED management. Very often these patients will present and they meet clinical criteria for PE, and our ER colleagues might want to order a CTA. We're tending not to order the CTA because we're concerned about further damaging the kidneys with contrast exposure. And note that we're going to treat these patients with treatment dose Lovenox anyway. And since this overwhelmingly appears to be a disease in which we have microthrombi, so it's going to be peripheral vascular, we're really not going to see those large central clots that you see with the CTA. So something to keep in mind. That doesn't mean that you should never get a CTA, but it should influence your clinical judgment at least just a little bit in this direction. So also note that this is very interesting in that in COVID, you have both an elevated fibrinogen level and D-dimer as part of your thrombotic disease. Now, this is different as compared to what we see in DIC. In DIC, we would see elevated D-dimer levels, but low levels of fibrinogen. And we don't quite understand why that is yet, but it's interesting to note here that this appears to be just really a different type of thrombosis. And that might have implications moving forward for us to better refine the use of anticoagulants in these individuals as more research comes out as to what is more effective for them. So what about melatonin? This was a really interesting paper here in which melatonin is involved in the cytokine cascade, particularly in the cytokine storm response. However, what it appears is that the dosages that would be needed would really have to come via an IV form of melatonin for it to truly shut down that immune response the way we would want. And IV formulations are both, one, not available, and we don't know what the side effects of treating with those high dosages would be. Now, that doesn't mean that there's maybe no benefit here. We are offering our patients melatonin at night in the normal dosages that we would, maybe 1, 3, 6 milligrams, and perhaps maybe that's offering some beneficial effect. but we are keeping that in mind that really we likely think that much higher dosages would need to be effective. So proning, this has been huge. And so this particular paper here focuses on self-proning, proning in individuals who are not intubated, but we're also seeing dramatic effects in individuals who are intubated. And so here, and we'll talk about this in a little more detail on a subsequent slide, really the acute respiratory distress syndrome that we're seeing in COVID is not the typical low compliance ARDS that we're more familiar with in our bacterial pneumonias or other viral pneumonias. This really is its own separate entity. It's really more what we're calling now CARDS, C-ARDS, because for the most part, many of these patients do not have compliance issues. Some do, but many don't. And perhaps that is what's explaining us seeing the dramatic effects that we see with proning. And so in particularly for our individuals who are not intubated, if they can self-prone on the floor, we're starting to see that these individuals are able to be discharged sooner from the hospital. They avoid intubation and they avoid ICU care. So this is huge. And so we're encouraging self-proning on all of our patients. And again, what we're seeing in our intubated patients is a decrease in length of intubation. And it is also important to keep in mind that you don't have to use a rotoprone bed. Now, some hospitals have access to a rotoprone bed, and there are many advantages to using that. But if you don't have a rotoprone bed, there are many tutorials online that are available to show your institution how to self-prone or how to prone in intubated patients without the use of a rotoprone bed, such as the New England Journal of Medicine. So what about a concept here of permissive hypoxia? So this is interesting. So in our ARDS patients, us as critical care doctors, we're already familiar with permissive hypercapnia having beneficial effects, but now permissive hypoxia? And why is this? Well, again, these individuals appear to tolerate hypoxia incredibly well, and mechanical ventilation can have many negative effects. And so here in this particular article, it talked about trying not to intubate early and why ARDSNet might be the wrong ventilator paradigm. And this is because these patients tolerate permissive hypoxia just extraordinarily well. And again, the ARDSNet paradigm might be causing more damage with the very high levels of PEEP because again, they don't have difficulties in compliance. And so what is the pathophysiology of what maybe is called permissive hypoxia or happy hypoxemia in these patients? Well, we're seeing intrapulmonary shunting, and that could be related to the microthrombi. We're seeing relatively preserved lung compliance. We're seeing lack of excess dead space. And also possibly a dysfunction in hypoxic pulmonary vasoconstriction, again, maybe where the use of flow and nitric oxide, or maybe something like milrinone maybe could offer some beneficial effects. And so what are some of our takeaways here? Well, what we know is that mortality rates in mechanical ventilation can approach extraordinarily high numbers, some quoting as high as 90%. I'm not really quite sure if it's that high, but the number here is listed just to show you that mechanical ventilation might not be the option. And then since patients tolerate hypoxemia so well, allowing permissive hypoxia seems reasonable. But then the question is how low do we go? We're commonly now seeing patients with PaO2s in the 60s, maybe even in the 50s on 100% oxygen. So their PF ratios could be 55, 62, something like this. And many of them look fine. They're looking at you like, why am I even in the hospital? And this is amazing because under normal ARDSNet criteria, these patients would be in severe ARDS, and we would immediately jump to intubation and maybe even begin rescue treatments on these patients. But if we allow people to go through this phase, many of them are going through it with not requiring the need of being intubated. And again, this is because this appears in at least most patients not to be ARDS, it's CARDS. It's not a compliance-related issue in these particular patients. It really is its own entity, CARDS. So now this is interesting. What about the use of CRRT in COVID-19? So for many of our European colleagues, they might have a little more familiarity in trying to treat sepsis with big cytokine immune responses that are maybe deleterious with CRRT to pull off some of the cytokines. However, what we have noticed is that, again, since these patients have that microthrombotic disease, we're clotting many filters. And it appears as if we needed a better filter. And so Baxter here came out with a better filter that lasts longer, that's more effective at removing cytokines. Again, think of that interleukin-6, bringing that back into regulation, as well as maybe being able to tolerate some of the microthrombi better. So what are some of our clinical takeaways? Well, this could have possible beneficial effect of cytokine clearance in COVID-19. You could have increased risk of filter thrombosis, so likely best to optimize the filter with this particular filter device. You might want to lean a little more towards permacaths instead of the temporary catheters, and that's only because they're larger in diameter. And being larger in diameter is really important because what we want to do is make sure that we run continuous renal replacement therapy. It has to run for 48 to 72 hours to be effective. We don't want the machine going down because of the filter or because of the line clotting. And so optimizing those two endpoints, the line and the filter, so that you can have the full run of CRRT is really in the best interest of your patients. So what about ECMO? Well, what we know about ECMO in some of the treatment centers is that use of ECMO in ARDS patients can have survival rates of about 70%. And initial data here is that initial ECMO survival rates for these patients can be as high as 62%. So it's really almost there for our standard VV treatment. And this is very encouraging. And so we're thinking about this if we're having patients present and they're very ill, and say they meet ECMO requirements or eligibility, to keep this in mind early and get those individuals to a facility that has this treatment available to them. So here I present hydroxychloroquine. So most centers are currently not using hydroxychloroquine, and it's not recommended for use, but I present this out of really humility. I present this because the information is constantly changing. And here is a meta-analysis of 5 randomized double-blind trials. And what they found here is that the early use of the drug by people who were not hospitalized yielded a statistically significant 42% reduction in the risk of infection, hospitalization, or death. Now, what they used here was composite endpoints, which means that they took 3 particular endpoints and put them together. So when you look at combined endpoints, maybe say hospitalization, mortality, etc., and you put those together, since you're putting multiple endpoints together, you have a higher likelihood of having some statistically significant benefit. But it is interesting to note here that it does appear as if there might be some beneficial effect, maybe not for us critical care doctors in the ICU, but maybe in patients outside. Again, perhaps maybe modulating that immune response so people have a better immune response to COVID-19. So thank you for watching. I hope you got something out of this, and please give your feedback here. This is by no means the only way of currently treating COVID, and I think one of the beauties for how we've successfully treated COVID to date is that we've been very open-minded and we've shared all of our information. And so just like I shared information with you, any information you can share with us would be greatly appreciated for us to have our unified goal, which is taking the best care of patients possible. Thank you.